Growth failure remains the most common presentation to a pediatrician with regards to a child, and often this provides us with an opportunity to overall assess the child, given that the growth is the best barometer of health of a child. Timely assessment and management of growth failure is pivotal to allow an appropriate diagnosis. However, given the complexity in the assessment of different parts of growth failure, including the growth chart, the bone age interpretation, as well as the algorithms as we are showing out here, it becomes difficult to really do an immediate growth assessment at the level of the pediatrician. And this really is a big challenge which we are today going to discuss as to how technology, while it is changing our own life, is disrupting our entire aspect, can help us in this regards. I'd like to thank Pfizer for providing me with this opportunity to and the platform to discuss about all these very, very important issues. With that, the whole basis of this talk, this whole initiatives and the technology initiative came back from around a case which I saw around 11 years ago when I came back from Australia, a 17-year-old boy with anemia and blood transfusion who had everything about celiac disease written on him. He had clubbing, he had abdominal pain, he had diarrhea, a clear-cut case of T2G positivity, and at that point of time we diagnosed him immediately. But before that, he had received blood transfusion 6 years ago, which had resulted in the development of HIV/AIDS. So from an entirely preventable condition, we were landing up in a complication which was really life-threatening of HIV. And this is when we were really shaken and we thought what could be done to increase and improve the outcome in this situation. The three issues which came to our minds were whether there was issues of awareness with regards to accessibility or affordability, and we finally came to the conclusion that awareness is the key, especially of the pediatrician. So we started with our initial growth workshop, which have now been conducted 100 places across IAP branches in India. Then we moved on to the practical pediatric endocrine courses, which have been done in 10 places as a full day program. We subsequently provided our information on YouTube channels and social media where it is still available. We then went on with a fellowship program. And finally, when we realized that whatever you do, you need to have a fallback option in terms of learning so people can go back and read again. So we started on MedEClasses online courses, which have been quite taken up in a good fashion. Now, even after that, what we realized that unless and until there is a way a physician is able to really access with regards to the immediate management in the form of a textbook, or more importantly in the form of an application, because everybody has got a mobile which can really help you immediately do a state-of-the-art evidence-based evaluation of a child with growth failure, we are not going to move forward. And then that was the birth of this growth app, and this is what we're going to discuss today as to how this can disrupt the overall evaluation and management of growth failure, providing uniform access across the part of the country. So MedEClasses app has been launched around 4 months ago. It's available across both iOS and Android platform. It includes the approach pathway, the management pathway, the calculator, the diagnostic, and the therapeutics. There are around 31 approach pathways covering every aspect of pediatric endocrinology, and as you will see, these are algorithmic pathways based upon the evidences. You've got management pathways which provide precise management guidelines. We have got analytical pathway which provides specific inputs as to the prescriptive format, and this app is really helpful with regards to a lot of pediatric endocrine things. And what we're going to discuss today is its role in terms of growth failure assessment and management. Now, growth failure, as we know, is common. If you go by statistical definition, we're talking about 2.5% or 1% of entire population, which is really huge. 80% people who come to a pediatrician actually have a physiological cause. 10%, however, may have a serious underlying disease. So while we do not want to have unnecessary evaluation in those 80%, we do not want to miss those 10% as well. So growth failure may be because of a life-changing disease like celiac disease or a life-threatening disease like craniopharyngioma. So therefore, a balance of this not missing or messing is essential, and therefore this will be the basis of what we'll discuss today in terms of assessment and management of growth failure. The key challenges that a pediatrician faces is in terms of the correct utilization of growth charts, and we have now got wonderful Indian charts which are available, but unfortunately many of them are not either used or not interpreted in an appropriate fashion. Bone age assessment is a big problem, and most pediatricians are not confident in doing that. Most radiologists are not really willing to do that. So it's a big catch-22 situation. And then finally, when you've got all the data, how do you interpret, and mainly how do you decide? And when you're treating, how can you predict what would be the expected response in that perspective? So what we'll do is that we'll go into all four of that as to see how each one of this has an important technological input which will improve the outcome in this setting. So we'll start off with the growth chart. The most important things to look in growth chart, and all of us know that we should select the appropriate growth chart. We should plot it with a precise birth date, and we should precise it as a dot. What we need to really look into a growth chart are three things. The absolute status as to how that child is comparing to a particular population, and this is expressed as percentile or standard deviation score. How is he matching with regards to parental expectation in terms of target height? And we all know that target height is calculated by mother's height and father's height divided by 2, adding 6.5 centimeters for boys and subtracting 6.5 centimeters for girls. And finally, the key question is whether this is a nutritional pattern growth failure and an endocrine pattern growth failure by looking into the height and weight age. So height age of a child is the age at which the current height becomes the 50th percentile, and the weight age is the age at which the current weight becomes the 50th percentile. And this dynamic interplay between the weight age, height age will give us a clue to diagnosis. So if the weight age is substantially lower compared to height age, we are dealing with a nutritional cause, while if the height age is lower or equal to weight age, we are dealing with an endocrine cause. So this all is very, very good in terms of theory, but when you talk about practice, it can lead to really complicated situations. So we'll go through some of those cases and how our intervention in terms of growth interpreter, which is part of this mobile application, helps us to reach a precise diagnosis and how we can interpret the growth chart. So we have this 12-year-old girl whose height is 132 centimeters and weight is 20 kgs. Father is 163, mother is 150, and if we can see, the child is clearly below the third percentile mark for both height and weight. So we will consider this to be a short if we talk about first in terms of absolute thing. Now next would be to correct for the mid-parental height. So what we do is that we put the MPH at 150 and then plus minus 6 centimeters, which represents one standard deviation for that particular age, and draw a parallel curve. And what we see out here is that this girl is, although short for the population, she is not short for the family. So this looks like a familial short stature. And finally, the third thing is to look at the height age and the weight age. And what we see is the height age is 9 years and weight age is also 9 years. So we have a girl who really looks short, is short for the population, but it's not short as far as the family is concerned. Now, if we see this may sound complicated, but this is what we need to do to really interpret it. Now, what we have done in our mobile application is that we have actually provided a growth interpreter, which is part of the analytic process. All you have to do is to put the height, weight, mother's height, and the father's height, and all of this will actually be done by the app. So we put all of this and we have put around 30 categories, and it will really give you what the height SDS, what the weight SDS, what the BMI SDS, what the target height SDS is there, and it will interpret that this is a familial short stature. So what key parameters we are getting out of it is, without other than the chart which is being plotted, it tells you about the height SDS, weight SDS, BMI SDS, which is pretty common, but it is telling us two things which are not easily available. The height standard deviation for bone age, which tells us, okay, his bone age is delayed, how is he as compared to the bone age, and the corrected height SDS, which compares it to the parents. And these two parameters will be crucial when we want to identify the constitutional delay of puberty and growth, as well as the familial short stature. And as we will see subsequently in our presentation, we will see that these are very, very vital in that perspective. And we have given algorithms based upon which this app will really give you the diagnosis. And when we talk about our evidence base as to how we have created that, we know that this is around 99% accurate with regards to classifying the growth failure in that perspective. So this is clearly a familial short stature. Coming to the second case, we had a 13-year-old boy whose height is 135, weight is 30, father is 170, mother is 157. So this is a common presentation. You plot on the chart, you see this is a short child, 13 years old. Somebody did bone age, which was 11 years. Prepubertal, so this is again a common situation. And when we plot it according to the height age and weight age, the height age and weight age are around 9.5 years. Now at this point of time, what this child looks like is that this child is short for the population, he's short for the family. Now the big question is, what do we do? So somebody had done all the screening tests which were normal, the CBC, SGPT, creatinine, thyroid, everything, and then a growth hormone stimulation was done which showed a peak growth hormone of 3.2, labeled as growth hormone deficiency. But the key question is it really growth hormone deficiency? And if we put all the data into the app, it will give you the clue. So we have put all the height, weight and all those data, and what we see from here clearly is, look at the height standard deviation for bone age. So this child is short for the population, short for the family, but not short for the bone age. And you can actually see on the growth chart as well. So this is 99.9% not growth hormone deficiency. This is most likely a case of constitutional delay of puberty and growth. And this workup was absolutely essential. So the basic dictum is that unless you have interpreted the growth in a proper fashion, you should never give any investigation or workup in this situation. So this is not GHD, it is constitutional delay of puberty and growth. We'll now head forward to the third case. 10-year-old girl, height is 120, weight is 15, and the mid-parental height is around 150. So the workup was done, hemoglobin was slightly low, liver and renal functions were normal, TSH was normal, TTG was normal, karyotype was normal. So somebody thought, okay, this is growth hormone deficiency. IGF-1 level was found to be low, basal growth hormone was low, and this was the growth chart. Now the question is that, is this girl really having a growth hormone deficiency? And when we did actually, the patient came to us, she had already received growth hormone with no response. So if we now interpret this growth chart clearly, we will clearly know that her height age is affected, but what is more affected in this case is actually the weight age. So this overall diagnosis of growth hormone deficiency is questionable, and when we put these data into our growth interpreter, what we really see in this situation is that once we assess, the key thing to look at here is the BMI SDS, and what we're seeing is the BMI SDS is minus 3.6. So this girl has a disproportionately lower weight as compared to the height, and we use a criteria of BMI SDS less than -1 as an indicator of nutritional growth failure, as we'll show how we got that evidence. This is not growth hormone deficiency. This case is actually, when we worked up further, a nutritional cause, and IgA was undetectable, and this was actually a celiac disease. So this really highlights the importance of a careful assessment of the growth chart, which really provides us with a clue as to the appropriate diagnosis in this setting. We now have an 8-year-old boy whose height is 100 centimeters, weight is 18 kgs, and the mid-parental height is 170. His workup was normal, his hemoglobin was 13.2, his TTG was 32. So now we have come a full circle. In earlier, celiac was something which was not considered, but now anybody who has got a TTG more than 20 is diagnosed as celiac. So he was started on gluten-free diet. But if we look at this child, what we really see is that his height is much more affected as compared to the weight. So this is very, very unlikely to be celiac disease, and there was no response to gluten-free diet. So if we had interpreted the growth chart earlier, we would have not diagnosed this as celiac, because without a biopsy in somebody whose TTG is less than 10 times the upper limit, we cannot label somebody as celiac disease. And so if we now look into our growth chart, what we're seeing in terms of growth interpreter is that the main thing to look at here is the BMI SDS, which is in the plus. So this is a clearly endocrine pattern growth failure. We need to be careful in this perspective, and this turn out to be growth hormone deficiency rather than celiac disease. So the use of growth chart appropriately, either the conventional or what we have provided in terms of our interpreter in the mobile application, can really transform the way workup is done and evaluate prospectively. The second major issue which is faced by every pediatrician in terms of the overall growth assessment is the bone age. Now, bone age is absolutely important, and we know that bone age has to be done for everybody who comes to us with growth failure, growth excess, precocious puberty, delayed puberty, and everybody requires bone age. It should be short stature, anything requires bone age in pediatric endocrinology. But what we get from the radiologist, we get reports like 5 to 17 years, no fractures. 0 to 99 years would probably be a best template to report, in that there will be no errors on that. So we need to really move forward from the abysmal way the bone ages are assessed and into a more logical way of assessing bone. Now, often if we look about somebody is asked about what is the best way to look at in terms of the bone age assessment, everybody tells us that it's actually the carpal bones. But what we need to understand is that carpal bones are the least important in terms of bone assessment beyond the first 2 to 3 years of life. Maturation happens from proximal to distal. Fusion happens from distal to proximal. So if we are actually looking at bones which are there in the carpal region, we will actually be picking up growth abnormalities very late. So we need to really evaluate at the right time, manage accordingly, otherwise this could be a big issue. We also need to remember that girls tend to have an advanced bone age compared to boys. So at different ages, we need to look at different age groups. For most cases, I would say the distal phalanges are the most important to look at in terms of bone age. The role of carpals and long bones are there in the initial phase. Very importantly, we need to have an appropriate X-ray to get the picture. Often the distal extremities, phalanges are cut, which is not appropriate. The finger should be evenly spread and the exposure should be proper. You should not have an overexposed film like this, which will cause a lot of confusion. Now, having said that, what we need to use is a left hand and wrist, or we can consider the non-dominant. But usually, because dominance is not very easily available on clinical practice, we as a rule of thumb use left hand and wrist in this perspective. The various methods by which bone age can be assessed include the GP Atlas, the Tanner-Whitehouse, and the Bone Expert. Now, all of them have their advantages and disadvantages. GP Atlas is an atlas in which you compare the different age groups. The problem is that there can be discrepancy between the different bones. Tanner-Whitehouse has therefore classified it into different sites, and the latest one has got 13 sites to look at. It's a tedious process, may take up to 15 to 20 minutes as well, and the reliability will depend upon the accuracy of the user. So it's a user dependent thing. Bone Expert is an automated assay which our hospital has been following for the last 5 years. We have done thousands of X-rays. It is reasonably good, but will be costing around 5 to 10 euros per analysis depending upon your quantum of work which is there. So there needs to be a practical tool to assess bone age, and that is extremely important, and that's what we have been working about. Just to highlight what idea we need to have in terms of the various bones, we need to understand that different sites become important for different ages. So in infancy, we can look at the number of carpal bones and how the small phalanges grow up. This is for the first 2 to 3 years. But for the most important phase of life, when we are evaluating somebody for growth failure, somebody for precocious puberty between 3 to 14 years of age, we are mainly looking at the comparison of epiphysis to metaphysis, which is there with regards to the various small phalanges, and this becomes important. This we'll discuss a bit later. Late puberty and fusion, which is not very relevant because by this time nothing much can be done. We can look at the long bones. So mostly a pediatrician, if you have to look at, is to compare the small phalanges and look at the size of epiphysis as compared to the metaphysis. So if the epiphysis is smaller than the metaphysis, we are pretty much talking about less than 8 years, typically 3 to 9 in boys, 2 to 7 in girls. Then 9 to 11, it becomes equal in boys, 7 to 9 in girls. So always girls are 1 to 2 years advanced. Once it starts to cap, we are probably entering around 11 to 12 years. And once this capping has happened, it's already too late. So looking at this particular site becomes important. But however, there is a lot of subjectivity which is there, and this causes a lot of confusion in this regards. So basically, if we talk about bone age assessment, what we need from a technological input wise is a simple and accessible tool which is validated against gold standard and which can be compared with Bone Expert, which even the non-experts can use. So what we did, we developed a novel way of assessing bone age, and this is a big advantage that we have now put forward with regards to our MedEClasses application, which is very easy to do. This was developed initially using 307 radiographs. Dr. Riddhi, Dr. Chetan, they looked into every radiographs, and then we selected the different sites for the 13 regions which are there as part of the Turner syndrome, as part of the Tanner-Whitehouse staging. Now, what we then did was that we compared these radiographs using 90 radiographs to TW3, developed accuracy regression analysis models, and decided to choose the best regions. Once we had done that, these were then validated against 205 radiographs by 2 experts for precision, accuracy, and various measures were used, including the Bland-Altman plot. This was then compared to the bone expert, which is the ideal one available in our hospital, in 205 radiographs with 2 experts using expert versus non-expert opinion. So we did, in terms of people who have done thousands of more bone age assessments versus our D&D students, in which we compared 100 radiographs, again application in Tanner Whitehouse, to look at the time, precision and accuracy. So based upon all this research work, we were able to really decide about the specific sites which are good to choose and how to go forward in terms of the scoring and the regression equation. So our current MedEClasses bone age application actually has got 7 sites, which we hope to come down to 5 with the next launch within a week. So only 5 sites have to be compared as against 13 for the standard Tanner Whitehouse. What basically involves is that you just have to specifically look at a particular age. You of course put the age and the gender, and then these films will then load, and these films will then be compared to the standard images that you're seeing on the X-ray. Once you've selected 7 in the current version, and hopefully in a week or so we will have 5 in that, which will give us idea. So the X-rays we are looking at the moment are the proximal, middle and the distal phalanges of the third finger, the metacarpal and carpal for the thumb, and radius and ulna, and you get the result of the bone age along with the range. So this is what we need to do. To do it in a more practical fashion, we'll show you like this 12-year-old boy. So the first site is distal phalanx that we are seeing in this situation. So we start off with this, and once we enlarge this image, all you have to do is to compare and see which is the closest image to that. So you don't have to look at any specific characteristics, you don't have to look at any specific pointers, how the image is looking, see which is the closest. So there are annual images. We actually selected about the 6 monthly and annual, we found annual does better. So just to compare which annual image does it look closest. So this was for phalanx 3. Similarly, you look for the different part, the middle phalanx 3, and then you decide, and you can go back, come forward. It's just a simple comparison of an individual site, so to speak. And once you do that, and once that is selected, you can then move forward to the subsequent images. In the initial phase, it may take some time, but usually the time comes down as you go forward from that perspective. So this way, what you have to do is basically to select the entire gamut of images, starting from the distal to the middle to the proximal phalanx. And once you have decided upon, and this is something you can easily work out, you put the X-ray in front of it, you compare all the images. So you have to collect 7 now, and we have now shown that 5 images on a larger sample size are as good as 7. So we have cut forward 2 of the images, again made it very simple in that regards. 2 which come from the middle finger, 1 from the thumb, and 2 radius and ulna. So now we compare the proximal phalanx. Similarly, you compare this for the thumb. So you will find an image which is closest to that on thumb for the proximal phalanx. Similarly for the metacarpal. And this is a very easy exercise. So all of you can go down and download the app and use it for the first 7 days. You can access entire part. You can go to the iOS or the Android store to do that. You compare the metacarpal, thumb, the radius, and then finally the ulna. So what we have done is that we have compartmentalized this entire aspect of bone age assessment, made it simpler in that perspective, and this provides us information in that regards. Now you will then get an age which also comes with a range based upon the age specific ranges that we have decided based upon our mean NSTs. Now when we compared this thing to the gold standard, what we found that when we compare to the mobile application as compared to the Tanner Whitehouse 3 application, which is also available, the intra-individual variability and the inter-individual variability was very good. So in fact, the mobile application had less issues in terms of precision. So there was a good concordance between the results from the app versus our own mobile application, and this was for the expert users. When we compare to the bone expert, we found that there are root mean square error, as well as the relative difference was significantly lower compared to bone expert, which is expected that you have a manual measure which gives a better accuracy than bone expert. So you've got good precision, better accuracy, and very importantly, the time for expert was cut down by around 70%, for non-experts by around 70% again. So there was a significantly quicker turnaround which we found in this situation. And what we found that even the non-expert users had an error of around 7 months. So if the bone age, let's say, is around 10 years, you are getting around 9.5 to 10.5, which is good enough from a non-expert perspective. You can do it in 2.5 minutes. So although the accuracy was lower for non-experts, our DNB students, it was still nearly the same for bone experts. So what we have probably brought with this mobile application is the tool which is precise, which is accurate, easy to use, good results with experts and non-experts, and this hopefully will really change the way bone ages are assessed, and we'll get more reliable information from that perspective. Once we have looked into the growth chart, we've looked into the bone age, the next issue is how do we interpret it and whether our interpretation is appropriate or not. And this really is a challenging issue. And there are guidelines which are there, and these are the Dutch guidelines. They are wonderfully put guidelines, but we have certain issues. If you look at it, this looks complicated from a pediatrician perspective, but if we look into it deeply, they talk about IGF-1 and IGF-BP, which at a very early stage, which becomes very expensive for our patients. They talk about a lot of other investigations in this perspective. So if we look at this cost efficacy of this, which we have really compared our own algorithm versus this, we are talking about a difference of around 3 to 4 times in terms of the cost which is spent to identify a case of pathology. So we need to have our own, because the clinical case presentations is different, the resources are different, we need to have a different way to really assess growth failure, and this is what we have tried to work out based upon our own clinical data, and then we have put it forward in terms of our algorithmic approach, which provides a rational way to assess growth failure in that regards. So if you talk about growth failure, the key question a pediatrician has to answer is it really growth failure? At what level of growth faltering shall we call it growth failure? Is it familial or not? Is it CDGP or not? Once we have done that, this is around 80-90% of all cases for a pediatrician. Then see whether it is a primary or a secondary cause, endocrine versus nutritional, and finally what was the cause. So what we have tried to do through our study, which is basically looking at around a significant number of patients in this regards of around 870 patients over a 2-year period who had entire workup which was there, and this manifestations was pretty similar for a pediatric endocrine clinic perspective, with around 50-55% being pathological. But if we extrapolate from a pediatrician perspective, 80% will be more in terms of physiology range, but this will really give us information as to how we can decide about when and what level requires evaluation, or maybe referral to a pediatric endocrinologist in this situation. So if we look at the height standard deviation score, we have got a specific way to look in terms whether it's -2 STS, only 2.5% of cases below that were actually pathological, which increased to 42.6% between -2 to -3 and 80.4% less than -3. So if somebody's height SDS is more than -2, that means it's nothing to worry. Don't worry, just follow them up. If it's -2 to -3, there is a 40% chance. Consider evaluation or follow-up. Do at least the screening test. Less than -3, you cannot escape. You have to do this workup, and this is a big thing which came out from our own study in this perspective. The next issue is it familial or not? We got this answer from this wonderful archives paper, which showed that most children are within -1.5 standard deviation score of their parents. So if the corrected height SDS is less than -1.5, it should indicate that we are dealing with a non-familial short stature, so to speak. Now the final question is it CDGP or not in this perspective? So to answer that question, we looked into our database for that 870 patients, and what we found that individuals who have constitutional delay of puberty and growth all have a height standard deviation for bone age less than -2. In fact, there was a big difference between -1.3 to -2.5 for the bone age. So we have to correct the height for the bone age, and that will give us a clue whether we're dealing with CDGP. So we choose a cutoff of more than -2 for height standard deviation for bone age as a marker for being a constitutional delay. Next question, of course, is it primary or secondary? And this is more of a clinical question. So you have to look at the faces, you look at the proportions, which becomes important. Once you've decided that this is growth failure, this is pathological, this is secondary, the big question is it nutritional or endocrine? And as we discussed, the most important thing to look at here is the height and weight age. If the weight age is less for the height age, it is nutritional. If the height age is less or equal, it becomes endocrine. So we try to look at a number of parameters which will help us differentiate. We looked at the difference with regards to the BMI standard deviation score, the weight standard deviation score, and the ROC curves. Now, if we talk about celiac disease in particular, which is the most common nutritional cause that we encounter in our clinical practice, we are basically finding that in that situation, there is no cutoff of BMI SDS or the weight height SDS which will help us. So what we are doing is that we are advising celiac screening in the form of TTG in everybody who presents to us with growth failure as a screening investigation, but other nutritional workup like renal tubular acidosis, like workup for inflammatory bowel disease will depend only if the BMI SDS is less than -1. We also looked at in terms of the role of IgA, and we found that if we did not find any individual who was TTG negative and who had got a low IgA unless their BMI SDS was less than -1. So we are recommending IgA only if the BMI SDS is less than 0.1. So this algorithm that we have developed is looking at not only in terms of our own Indian data, we're also trying to cut off investigations in this regard, and this will show once that algorithm comes into the picture. Now, we have done a lot of things in terms of it's a pathological cause, it's a secondary endocrine versus nutritional. Now, what's the cause? And this involves history. Look for a comprehensive assessment for the GI symptoms, which will suggest celiac. IBD is important. For that, fetal calprotectin becomes important. Hearing abnormalities suggest Turner syndrome or pseudo-hypoparathyroidism. Rickets suggests celiac or renal failure. Polyuria obstructive symptoms for RTA, for renal abnormalities, pulmonary symptoms for asthma, tuberculosis, and cystic fibrosis, and finally neurological features. Careful examination becomes absolutely important in the setting to look for dysmorphism, as we discussed, for body proportion. Micropenis suggests hypopituitarism. Anemia in a child with growth failure suggests celiac or renal failure. Clubbing and nails are very, very important. If we see clubbing, it suggests celiac or chest infection. Hyperconvex nails suggests Turner syndrome, as well as brachymetacarpia and pseudohypoparathyroidism. So based upon all these constellation of things, as well as our own data of 870 patients in which the extensive workup was done, we have now come forward with the algorithm which has been used in the growth interpreter and analyzer that we have done. So anybody with a height SDS more than -2 doesn't require evaluation. Somebody between -2 to -3, we look at corrected height SDS to look for whether it is familiar or not. If the corrected height SDS is more than 1.5, it means it is familiar. And you just need to follow up, if the height SDS corrected for the family is less than 1.5, it means it's a non-familial cause. Look at height standard deviation for bone age to identify CDGP. So after familial, CDGP. If the high standard deviation for bone age is more than -2, and all these parameters are actually there when we look at our app in the growth interpreter. So everybody can analyze and then put the data and they will get the result. So if the height standard deviation for bone age is more than -2, this is constitutional delay of puberty and growth, and you just need to follow up. If it is not there, look for screening test, and these screening tests we've included basic workup, CBC, ALT, creatinine, electrolyte, TTG, FT4 TSH, and blood gas before 3 years of age, because we have not seen RTAs beyond 3 years of age just presenting with growth failure. So these workup are essential, and remember, TTG is done for everybody, even if they do not have a nutritional pattern of growth failure. If they are normal, we follow growth over 6 to 12 months, and we use 25th percentile for age as per the Indian data. And if these are also there, then we have to think about further workup. On the other hand, everybody who is less than -3 standard deviation score, remember, it's 80% pathology in our study. So we do not look into all the corrected height SDS and height SDS for bone age there unless somebody has a very clear-cut case. So this is definitely workup starts there. Look for faces in proportion. Look for screening tests. Again, the same screening test. And if the screening tests are normal or the growth is low, so somebody who is -2 to -3, we do not advise unnecessary workup for everybody to begin with. We do a screening test. We look for faces in proportion. If that is normal, we follow up. And if the follow-up growth is low, then we advise to look at basically the BMI SDS. If the BMI SDS is less than -1, the remaining nutritional causes like IgA, blood gas, and fetal calprotectin about 10 years is done. Then if it is normal, or if it is normal or the workup is not there, we start doing karyotype. So remember, we're not doing karyotype for everybody to begin with. If karyotype is normal, we do growth hormone stimulation test and diagnose GHD if it is less than 10 as partial. If it's less than 5, it is complete. And only if the growth hormone stimulation test is normal, we are doing IGF-1. If the IGF-1 is low and growth hormone is high, it is growth hormone insensitivity syndrome. If the IGF-1 is normal, we look at birth weight to differentiate SGA and ISS. So if we just summarize this, the key part of this algorithm is that we are not unnecessarily evaluating everybody who is less than -3. Only more than less than -3 we are evaluating. -2 and more we are not evaluating anybody. Between -2 to -3 standard deviation score, we look for familial by looking at the corrected height SDS as well as CDGP by using height SDS bone age. If corrected height SDS is less than 1.5, if the height SDS for bone age is less than -2, we are then evaluating with screening test. If that is normal, we look for facies proportion and then we decide whether the further nutritional workup is done or not. TTG is important, so we are doing it right at the beginning. IgA, blood gas, and fetal calprotectin is only being done if there are evidence that there are features if the BMI SDS is less than -1. Very importantly, karyotype is late, not in every girl. After only we have excluded all those. Growth hormone later, IGF-1 at the end. So if we compare the cost for this analysis to the Dutch, it is less than 15% per pathological cost. So this is going to be really helpful. And this is how this works. This asks what's the height SDS, then we talk about syndromic features, we talk about proportions, we talk about the screening test, we give all the tests there. Then if the screening tests are normal, we ask about BMI SDS, then we suggest that okay, this is normal, then we say do a karyotype. If the karyotype is normal, we talk about growth hormone. We'll give information about how to do growth hormone testing there as well. And then if the peak is more than 10, we say now do IGF-1. IGF-1 is normal. Look for the birth weight, which is normal. So this is SG, idiopathic short stature, basically. So all this algorithm is already feeded in the mobile application. You don't need to do, you just have to answer a few questions. And within 8 to 10 questions, you will get your final diagnosis. And when we actually evaluated this in our own study, we found that the efficacy was around 99.5%. So 99.5%, there was a concordance between what the clinical outcome showed and what was found on the app. So this is quite easy, handy tool which can really help in terms of proper evaluation and assessment in that regards. And the development of the entire mobile application has been a long drawn process. We have been helped by Dr. Yutika, who has helped in planning the process. We've got the implementers, Dr. Neha, Dr. Chetan, Dr. Riddhi, Dr. Sajli, Dr. Hemang, who have looked into every aspect, and we've discussed only about growth. It talks about puberty, it talks about rare cases like adenocortical hypertension, it talks about DKA management, a lot of other things. And we've got an executive panel, Dr. Shalabji, Prabhat Dikshit, and Dr. Mittal, who have played a long role. So this is an application which is really helpful in terms of we focus on growth. A lot of these things and many of these things, research have already been recognized as the best oral presentation in ISPE for bone age, best poster for the growth app, best oral presentation in the IAP research conference in Delhi. So this is something which is going to really help in that regards. So now we have discussed about the growth chart evaluation, the bone age evaluation, the interpretation of growth chart. Now comes the issue of prediction with regards to that. And this is important from a therapeutic perspective. So we have an 11-year-old boy with growth failure. Height is short, weight is 27 kgs, prepubertal, GHD. Now what dose to use? How much do we expect him to grow? Whether we can change the doses and see if he improves or not. And this becomes an issue because he grew only 7 centimeters. We said he should grow 10 to 15. So there is an issue of responsiveness, and everybody does not respond same. So there are different responsiveness that is seen with regards to growth. 70 to 80% of this variation can be identified based upon known predictors, and this has been done using large databases, and this will help targeted therapy and also get information on dose and responsiveness. So while we're talking about technology, a wonderful prediction model has been developed by the iGrow model, which basically looks into these basic clinical parameters, and based upon that, looking on the simple things like age, height, in terms of parental height, IGF-1 level, GH level, it gives us the idea for growth hormone deficiency and Turner syndrome, how much to expect, what will happen if we increase the dose or decrease the dose. This becomes easy in that perspective. So technology has really changed in terms of overall management, and our MedEClasses app is covering entire aspect of pediatric endocrinology, starting from around 31 approach pathways, covering everything in pediatric endocrinology, from basics like growth failure to endocrine hypertension to things like Cushing syndrome, hyperprolactinemia. Everything is there in that perspective. 13 management pathways, personalized management for conditions like DKA, growth interpreter, and this app can be easily identified and obtained from the Android as well as the Apple Store. We also offer masterclass in pediatric endocrinology, which is again a technology intervention. This covers over 90 modules in every aspect of pediatric endocrinology using animated videos, using a number of specific tools, which helps a lot. So I would like to really thank Pfizer for allowing me to use this platform to really disseminate this important information about pediatric endocrinology. And I hope that this technological advancement will improve the care of pediatric population with regards to growth evaluation and management, and we'll publish our own data on this regards.